Welcome, everybody. It's a great pleasure to be here with you in this forum and event, which is co-sponsored by the School of Public Health and the Center for Health Policy Research. It's really a joy to be working together on what's such an important issue for all of us. So, you may have heard the quote, the single most important word in democracy is we. So it's President Obama, interestingly, he's cited as saying this when he stepped down, and I guess we're not surprised. He knew we had become important when he stepped down, but he actually said this during his presidency as well, when he had enormous power to act as an individual. It is the beginning of our Constitution, we the people, so why start there today? It's about what these forums are about. So our hope is that this will help all of us learn, listen, discuss, debate, and be engaged in these issues that are actively being decided. I think we're all here, and those who are joining us online are with us because we share a belief that every single human being has a right to health. We may have different views on the best way to get there. There may be ways to improve our system. There may be changes that can make it better and changes that make it worse. We hope that this series that we offer will give everybody a chance to form your own opinion about what makes a difference and to actively be engaged with that information as part of the we that will really shape the future of health in the United States. So we're going to work hard to make sure there's room for discussion, questions, debates. That means that our fantastic panelists who could speak at length and have an enormous amount to give on this subject are each going to speak relatively briefly so that we can then get into the dialogue. I'm going to introduce them all right at the beginning and ask them to come up as I introduce them so that we can go straight here from the panel and then open it up for the discussion. So it's an enormous pleasure to welcome Louise McCarthy. Please come on up. She's the president and CEO of the Community Clinic Association of Los Angeles. In this role, she represents the interests of the LA area community clinics and health centers and those they serve. She's worked on the California Bureau of State Audits, conducting performance evaluations. So she's grounded both in how we get services directly and how we do it well. Please come on up, Louise. Also joining us is Laura Corey. She's Senior Vice President and Chief Strategy Officer of Children's Hospital Los Angeles and the Children's Hospital Los Angeles Medical Group. Laura works with the hospital and its physicians to develop a system of care for children in LA and beyond. This includes developing performance management of the hospital's primary care and community provider network. Again, how do we get the best care and how do we do it at all levels? It's a great pleasure to welcome to this panel Jack Needleman. I know many of you know him. He's professor and chair of the Department of Health Policy and Management here at the school. His recent research focuses on quality and staffing in hospitals and on the evaluation and design of performance improvement activities. In addition to these roles, he serves as Associate Director of the UCLA Patient Safety Institute. And last, my co-host, Jerry Kaminsky, Director of the UCLA Center for Health Policy Research, Professor of Health Policy and Management. He also serves as an Associate Director of the California Medicaid Research Institute and represents UCLA in this multi-campus collaborative effort. Jerry, for those who know his work, has been at the forefront of addressing the impact of the Affordable Care Act before it's passed and through this whole transition. So welcome.
Thank you very much, Jody, and thanks to the panelists for being here today. I'll keep my comments brief and more general. So today's session is what is going to happen to the safety net under ACA repeal. And first and foremost, I want to remind everybody in the room and in our audience today, remotely as well, that the ACA has not been repealed yet. It still is the law of the land. We've just finished going through an open enrollment period. There are still roughly 14 million Americans who are enrolled in Medicaid programs throughout the country as a result of the Affordable Care Act. And there are approximately 12 to 13 million people who are signed up in insurance exchanges throughout the country, 90% of whom receive federal subsidies to buy insurance, and that mechanism is still in place. With regard to the likelihood that the law is going to be repealed and replaced, we know that this is the stated objective of the Trump administration. And we know that there are many members of Congress, many Republicans, who want nothing more than to get rid of what they consider to be a horrible law. The problem that the Republicans face in repealing this law is that they can't do it simply with a simple majority. They need 60 votes to get rid of the law completely. And that's the challenge that they face. They also, when they propose a replacement plan, are going to need 60 votes to get the replacement plan in place. And that's going to be a challenge. So their current strategy is to make changes to the law until they can come up with a replacement using what's known as the reconciliation, or basically the budget process. And there is a lot of damage that they can do with the budget process. They can cut off funding for certain aspects of the ACA, but the price that they pay for doing this is political. And despite the fact that the country is as divided as it has been at any point in the last 50 years, and many of us in this room have lived through very divided times, the Republican Party is not unified in its approach to a replacement plan. And as a result, there are more moderate Republicans in Congress who are very concerned right now if the ACA is defunded, if there is not a replacement plan in place, that there are tens of thousands of individuals throughout the country in each legislative district who may lose their health insurance, and the Republicans are not going to be able to blame this on President Obama anymore. They're going to be responsible for taking away the health benefits of constituents in their districts. There are a lot of Republican members of Congress right now that are very nervous about finally being held accountable personally for taking away the health benefits of their constituents. I'm not saying they won't try to blame President Obama, and in fact, I'm sure that there are very creative people right now in the White House that are trying to figure out a way to take away health care benefits and still blame it on the president. And in fact, we can hear the rhetoric already. Part of that rhetoric is the program was failing anyway. And what I see happening right now is that the program right now, there's instability in the marketplaces, and there may be more instability next year because the Republicans are making it unstable. They're creating the uncertainty, and as a result, they're saying, we'll see, it was going to fail anyway. But they're the ones who are creating this instability, not the Democrats and not the former president. The other panelists are going to talk about the impacts. Dr. Needleman is going to talk about what I consider to be a very devastating aspect of Republican plans, and that is to convert the to convert the Medicaid program into a block program. That's sort of related but separate to the ACA, and he'll talk about those consequences. But the bottom line is that the repeal of the ACA, regardless of what the replacement plan is going to be, it is going to have a devastating impact on vulnerable populations, on people who've gained insurance coverage over the last 4 years. And it's going to be felt by institutions like the ones represented by our other panelists today. So I'll end my comments there and turn it over to Dr. Needleman. Thank you.
As Jerry alluded to, I've been asked to focus on the Medicaid component of the program and think about the impact on the safety net, but also think about the nature of potential repeal as part of a broader strategy. I want to begin by really mentioning what the Affordable Care Act did to Medicaid, and in the 4 minutes I have time, it's going to be a very brief description. The core thing is it raised the income eligibility level for Medicaid and removed some of the family composition components to eligibility. It made Medicaid potentially available to individuals with incomes up to 138% of poverty. Under Supreme Court ruling, the expectation was, even though it was nominally voluntary to expand Medicaid, the penalties in the original bill were so substantial that it was expected every state would expand Medicaid. Under Supreme Court ruling, which said the feds could not impose the problems as they were established in the bill, the penalties as established in the bill, it became voluntary. 31 states and the District of Columbia adopted the program, including many that were governed by either Republican governors or Republican legislatures or both. 19 states, overwhelmingly Republican in their governance, have opted not to do the expansions. Those expansions have had major consequences in the states that had them. Jerry mentioned 14 million people who have gotten coverage. Actually, about 11 million of those were people in that new expansion group. And an additional 3 to 4 million people in that expansion group were people who had been previously eligible for Medicaid, but were not going through all the time and effort to get the coverage. And the creation of the exchanges basically reduced the level of effort needed to get expansion. So many people who had been previously eligible for Medicaid but didn't get it also got Medicaid. Combined effect of this is to substantially reduce the number of uninsured in the states that adopted the expansions, and give people an opportunity to walk into Children's Hospital or community health centers with insurance cards rather than being fully covered under other kinds of payment from them. If the program is repealed, those insurance or cut back, those insurance options will go away and the number of uninsured will go back up. This is important because one of the things that the ACA also did is, recognizing insurance would go up, it began phasing out federal funding for disproportionate share payments to hospitals and other safety net providers to cover the uninsured. So the other source of funding for these folks are going down on the theory the expansion would be increasing. If this is reversed, I do not expect that money to be put back in the budget. The issue of repeal is interesting. Jerry mentioned reconciliation as the vehicle for doing repeal and replace. And actually, reconciliation is limited to affecting either government spending or government taxing. And because Medicaid is basically a program that's built around government spending, all these changes in Medicaid could, in theory, be fully accommodated in a reconciliation repeal of portions of the bill. Jerry mentioned the politics of doing this with respect to many Republican states having expanded the program and seeing 10,000, 50,000, 100,000, 200,000 people get covered as a state. Governors not being eager to see those folks lose that coverage and be so you've got the politics of whether or not full repeal is possible. The issue of block granting goes back for a longer time. This has been on the table as one strategy for reducing federal investment in Medicaid by capping the amount going to states and basically trending that capped amount forward based upon an inflation factor that's lower than the expected level of spending. So shifting more of the future costs of the program from the federal government to the states. Some states want the flexibility. Other states don't care about the cutbacks that would occur to accommodate the lower level of funding. But in many states, this is a major issue, so one can expect pushback on this through pushback on block granting. But in addition, the fact that some states have adopted the expansions and others haven't means that levels of spending in states on Medicaid per person, per capita, are very different in the states across Medicaid. And any effort to block grant is going to have to deal with how to deal with a grandfather in the higher level spending in the expansion states, or reallocate from expansion states to other states, both of which have major political challenges to accomplishing them. So thank you. So with that, Lisa?
Good afternoon. As mentioned, I'm with the Community Clinic Association of LA County, and we are all of the nonprofit community clinics and community health centers from Antelope Valley down to Long Beach, from Venice all the way into the San Gabriel Valley. So that includes your federally qualified health centers, your community clinics, your free clinics, and your Planned Parenthoods. So thinking about what's at stake when it comes to the repeal of the ACA, we really look at the last 5 to 7 years of expansions, of growth, of improvements of care, and what's really happened and what we've done over this time, and then peeling that out and saying that's what's at stake. So essentially, it comes down to lives, it comes down to jobs, and it actually comes down to our entire county economy, given the role of healthcare and healthcare spending in our GDP. So just thinking about that side from the lives, 2010 to 2015, we saw massive growth in the number of health centers and the number of patients they served. We went from 1.2 million patients in 2010 to 1.5 million today, a 23% increase. We went from 53% uninsured in that original population to 33% uninsured in the folks we're seeing today, okay? And the Medicaid piece of this is what's really grappling for us, is we went from 29% Medicaid to 57% Medicaid. Medicaid is now the majority insurer in most clinics. If you go into a Planned Parenthood, Medicaid is 80% of their funding. So think about that. When we look at the number of sites as well, new sites and new organizations have popped up all over the county. There's been incentives and grants, and folks expanded because, not just because those grants created those sites, but because the coverage that came with it allowed them to make new sites and new services available. We went from 300 to 350 sites. We were able to staff those sites because of the coverage that came with it. All of that is what's at stake. In the area of jobs, LA County has around 600,000 healthcare jobs. 23% of those jobs are middle skill, meaning they require a high school diploma, but less than a bachelor's. So those are jobs for economic growth and economic development within our communities, okay? As we look at the number of jobs that are at stake, if we repeal the ACA, I believe it was UC Berkeley put out 63,000 jobs in LA County now at stake due to repeal. Let's pull that into a health center. So if you're in Antelope Valley, our one congressional district that happens to be Republican, you go to Antelope Valley Community Health Center, they went from a mobile clinic with 25 employees to a full-fledged federally qualified health center with 235 staff, right? In JWCH Institute on Skid Row, 255 employees in 2010, 477 in 2015. Those jobs that they added, they're all at stake. And then on the question of the economy, analysis now looks at a $5.8 billion impact on our county's GDP, if even under partial repeal. When we think about what the impact of healthcare spending is on GDP, back to Antelope Valley, they invested $3 million in construction firms. These aren't healthcare jobs, these are construction jobs that benefited because of healthcare expansions. They also invested an additional $872,000 in contracts for facilities, services, maintenance. This is all going directly into their community. JWCH on Skid Row put in $5 million in construction, and they put in $3.3 million in ongoing service contracts for facilities, et cetera. So as we look at what's at stake, the repeal is not just about our system and our coverage and what happens in our own shops. It is about the fabric of LA, and it is about our communities as a whole. So We are working on it. The Affordable Care Act anniversary is next month, March 23rd. Please mark the date. Keep a lookout. We'll invite you to come march with us. Think about telling your stories. Think about folks you know in other districts outside of LA County that might have an impact and might need to know about what the impact of the ACA is. So we will be also in DC in March and telling our stories. But to the earlier point, it hasn't been repealed yet, and that is a victory in and of itself. But we have to continue that fight, not just on that side, but I'll say as well on the questions of immigration, LGBT civil rights, as well as access to reproductive health care. Those are all things that will end up impacting us. So thank you.
So I'm just going to pile on with the good news. So thanks for having me. I'm going to ask for your forgiveness. I am going to be a little bit parochial today and really focus on kids because that's what I do all day. It's an interesting context to think about access to care for children. We have been fighting for complete coverage for kids in this country for a long time. And I'm happy to report that we actually achieved that before the ACA. And so between Medicaid and the CHIP program and a few other programs, we've been able to cobble together coverage for kids. And the Medicaid program is actually the place where most of that coverage resides. And so as we think about ACA repeal, as others have mentioned, unfortunately, it's not just about ACA repeal. What we're finding is that all of these programs are being reconsidered. And I have to say, I'm a little bit concerned that because of the difficulty of ACA repeal and its prospects, which I know there's a lot of commitment to from a lot of people, the conversation around Medicaid reform is actually gaining a little bit more attention than we would like. So that, there's a piece of ACA that's about Medicaid expansion, but there's the original Medicaid program as well. And so we're now having block grant conversations around Medicaid, and that has a lot of implications for us. Just a little bit of a sense of how Medicaid plays out for kids. Nearly half of the folks in this country who are covered by Medicaid are children. So 50% of Medicaid beneficiaries are kids. 20% of the dollars spent in the Medicaid program cover children. So kids are a disproportionate number of lives under that program, but spend less than their fair share. And so as we think about reopening the conversation around Medicaid and the ACA, as Dr. Needleman mentioned, we also start to reopen conversations around other financing streams that allow safety net providers to survive. So if we think about Children's Hospital Los Angeles, about 72% of the kids that we take care of are insured under Medicaid or CHIP, some version of CHIP. About 63% of the dollars that we generate for patient care services are related to those kids. So 63% of our revenues are in context for reform conversations. And that's combined between our Medicaid program and our provider fee program. So I will kind of pile on to the concerns around the disproportionate share program. Here in the state of California, which I'm sad to say is actually the fourth worst payer for Medicaid services in the country. So that's when you're not happy to be in the top 5. We've managed to supplement those payments historically with some disproportionate share dollars, but we have a pretty substantial provider fee program here in the state. And so safety net hospitals like Children's Hospital Los Angeles have relied substantially on those dollars. We're concerned that concurrent with the Medicaid reform conversations, there are also going to be conversations around reform for supplemental payment programs like the provider fee program. So just want to kind of add that to our consideration set. The risk that we face as we think about kids with the reforms that we're talking about, so thinking about whether we're going to end up with a Medicaid block grant model or a per capita or per beneficiary model, The idea that, that reformers are putting forward now around Medicaid is shifting the oversight and responsibility and guidance for those programs along with the financial responsibility onto the states. And so much of what has been put into place to protect kids is actually federally required. So we have requirements around the set of benefits that are required by Medicaid programs for kids. And that's assured that kids have access to the things that the American Academy of Pediatrics, the pediatricians who know how to do this well, have said kids should have access to. Now, we all live in California, and we say, phew, we live in California. But I can assure you that every state, in facing a Medicaid block grant scenario, is going to have to start to make some choices. And in a state that has done Medicaid expansion, so we've added 3.5 million folks to our Medicaid rolls very gladly and very appropriately. If we decide that even in the face of ACA repeal, we want to continue to have that expanded population, the folks who are in those programs are going to start to face pressure relative to the benefits that are provided, relative to the access to care that they have, and relative to the providers who are willing to participate in those programs. And so I want to kind of reinforce this point that kids are particularly exposed as we think about this type of service, of reform, because of the substantial reliance that kids have on the Medicaid program. And as we think about these reforms, we're going to need to pay special attention to kids to make sure that the benefits that they have and the access that they've had is not interrupted. You know, we have a particularly fragile population of kids who fall under the Medicaid program, and those are patients who are particularly complex. Here in California, we have a program called the California Children's Services Program, and that has assured that kids who have special healthcare needs are able to access the right services, and that they're able to get the benefits that they need to be taken care of. That will be at risk. It will be at risk in a Medicaid reform scenario. It will be at risk at the state level if we think about a block grant scenario. So lots of things for us to worry about with respect to children, and children's hospitals are disproportionately affected because we disproportionately serve Medicaid beneficiaries. And that's true here in California as well as across the country. So another important asset for our communities, and I'll echo Louise's point around jobs and the economy, really integral components of our economy that are potentially going to be affected. So you know, I would suggest that as we think about action and we think about advocacy, we need to pay attention at the federal level, and we also need to pay attention at the state level. And the challenge that we're all going to face as we're doing that is to make sure that we're advancing the interests of our constituencies, but putting it into a larger context, because the one thing that's for sure is that there's going to be less money to take care of more people. And so our challenge is going to be to figure out how to do that in a way that protects our future, secures our economy, and assures the health of children to come. So I'll leave my comments at that.
Thank you so much. So I know there's so much expertise in this room, and there's a lot of expertise online. If you're online, do type in your questions. We're going to alternate between the room and online. And if you're in the room, if you can throw your hand up, then Eric can try to make his way to you so everybody can hear your question. While we see some hands go up, I have one for the panel to get us started, and then I'll give Eric time. First, anybody questions? Concerns, debates, disagreements.
Don't be shy.
Different views. So let me just mention one thing about the ground rules. If there are things you did not understand, know that there are other people in this room who did not understand it. So if you don't get why we care if there's a block grant, don't be shy to ask. If nobody else, I think I get that, but if nobody else asks, I will start to ask some of the questions that are things I heard that people might have assumed everybody knew, but maybe everybody didn't know. But don't be shy about those questions. And if there are things you disliked about the ACA, you were worried about the cost, you were worried about how many people were in the market, don't be shy to raise those issues. I'm going to throw out one question to get us started, which is, this debate is opened up now in Congress. I'd love to hear over the course of our remainder of time from each of you, is there a change you'd like to see? If you were asking for something to happen that would change the ACA or change Medicaid or change the safety net and make it better, what would that be? And while you're thinking about that, if we can see any hands for Eric to go to.
So I'll jump in on something I'd like to see, and I'm just going to be Pollyanna about this, so bear with me. I would like to see income inequality be addressed so that we don't have to have 40% of our population in LA on Medicaid. I mean, that really is the big story that we see here, is that we have a county which is living at the poverty level and in a place which is so expensive to live in. There's a UCLA student living in his car, expose on the news. I mean, this is a challenge to live here. I would love to see the conversation go on to why do we need these programs and how do we go upstream and fix the demand as opposed to continuing to monkey with the end result. So I'll just be Pollyanna and put that out there. I don't think it's coming, but there you go.
Yeah, so this is the bleeding heart liberal panel. So I think the changes that any of us would like to see are about making the program better and not making the program go away. But one of the reasons why the opposition to the program developed, even among people who potentially benefited from it, was the individual mandate, the requirement that people buy insurance, and that was associated with subsidies, for income-related subsidies for the insurance. First of all, I think the availability of income-related subsidies was not made as clear as it needed to be, so there's a marketing issue there. But beyond that, the subsidies are frankly too low. They should go up higher in the income distribution. They should be a bit richer. People should not, and coupled with that, the quality of the policy should be made a bit better. People should not be looking at having to pay several $1,000s a year out of pocket for premiums and then confronting another $3,000, $4,000, $5,000 out-of-pocket expense to meet their deductibles and co-insurance. So if I were looking for changes in the program, I would be making the benefits richer by reducing the copays and deductibles, and I'd be looking to increase the subsidies, none of which I expect to happen in the current Congress.
So I'll jump in next. Jack stole my thunder because he's absolutely right. In a Clinton administration, we would have been talking about expanding the subsidies to make insurance more affordable. But there's another component, and I don't mean to get down too technically in the structure of the ACA. But one of the reasons the market became less stable this year is that there was a phase out of subsidies to insurance companies. And insurers have been subsidized over the first 3 years of the law to basically reduce the risk of enrolling patients who are too sick and extremely high cost. And the primary mechanism was reinsurance mechanism. When that phased out at the end of 2016, insurers got very nervous, and some of them increased their premiums substantially to protect themselves against the fact that these subsidies from the government, direct subsidies, were going away. I would have kept that program in place and phased it out over a much longer time period. Ultimately, the insurance industry ought to be able to price policies correctly in this marketplace, but they basically had the subsidy for 3 years. I would have extended it for another 7 and given lots of time for the market to stabilize. But we're not also going to see that change either. So.
Can I issue a two-part fantasy? So I think the first, which may be a little bit accessible, is I think we need certainty. So we've experienced in the world of children either annual or biannual needs to reauthorize coverage for kids. Between our our Children's Hospital GME program, which pays for residency training for pediatricians, and the CHIP program, we are having to get reauthorizations all the time. And so we've experienced this uncertainty, which is like a small example of some of the uncertainty that folks have talked about. So health plans will talk about uncertainty, people who are seeking insurance will talk about uncertainty, and providers will do the same. And so I think that as we move forward, and this, I do appreciate the fantastical nature of this, but I think that we have to seek a long-term solution, one that is not going to sway with who the president is and who's controlling the Congress. You know, if there's a lesson learned from that, from the ACA, I think that's one of them, which is that something moved forward that was at risk the day it passed. And so that's a very difficult context to build an economy on, to build an industry on, and to think about our future around. So I think that idea of certainty is an important one. And I would suggest that part of that conversation is a national conversation and conclusion on whether we really think this is a market-oriented solution set or we need to have a single payer conversation. I'm not suggesting which one of those is the answer, but in some ways, that's the thing we're still struggling with. And so I do think that if we do this right, we need to have that conversation, come to a consensus, and try and put forward a policy solution that has some longevity.
So I'm going to jump in with two questions from online and let people pick which of the two they want to answer, but hopefully across the panel we'll get both. Does anyone take comfort from the Cassidy bill that would give states the ability to keep the ACA if they want to? That's one question. And the other question is, so these are both state-based questions. How is California particularly vulnerable to block grants? Does California being the fourth worst Medicaid payer factor into this? So on a state-based approach, is there a state-based ACA, and what are the particular vulnerabilities around the block grants in California? And whoever takes the block grants, please make sure everybody understands how they function differently.
So some folks felt really relieved a while back. They said, well, you know, California, we enacted our own implementation language for health reform, so we're good, right? It's got a poison pill in it. If the individual mandate goes, all of the stuff that we built, covered California, you name it, goes away. And so you need to have legislation to put that back in place. On the question of, you know, for us, Medicaid is the biggest issue in LA because of the folks that we serve, and for folks in other parts of the state, it might go higher up the income scale. But the question when you block grant Medicaid, there's three decisions to make. Three. What will the benefits be? What will the eligibility be? And what will the payments be? And that is where the push and pull of a state that already has poor payments to providers, whether those payments are to the health plans, the hospitals, community clinics, we're a poor payer already. We've already taken a tax at eligibility and put in place processes to churn people out of coverage. And those are in Democratic governors as well when they're looking at, it's a better budget if people fall off coverage for a couple months at a time. And looking at the eligibility rules and the benefits. We've already had to fight back benefits relative to dental, optometry, those decisions about what benefits and what costs you're willing to pay for end up impacting the communities and the providers. So that's the place where we feel vulnerable because we have gotten out of our budget bad times, but that's with state Medicaid with the state governor who already tried to bring block grants to the federal government. He already tried, and luckily those were denied by the Obama administration. Per capita cap, it's the same thing. It's just the dollar isn't, here's $1 for your whole program, here's $1 per person, now make it work. So both are bad, and if people try to say one's less bad than the other, either would be disastrous.
So I'll address the Cassidy Collins bill. So do we take comfort in the fact that two Republicans have introduced a bill that would allow states to make a decision about whether they want to keep the ACA? Well, I think symbolically there's some comfort in that, but the likelihood of that bill passing seems very, very, very slim to me. I just can't imagine how a majority and how 60 votes in the Senate will allow a bill that allows the ACA, even if it's based at the state level, to continue. It feels to me like there's got to be some symbolic act on the part of the Republican Party to say we've gotten rid of this law. Now, I don't think that it's going to be easy to do. So there's going to be a lot of spin involved. And the spin will be, well, we didn't repeal it, but we've changed it in such a way that it's more consistent with Republican values. And we've actually seen this in individual states that have agreed to expand their Medicaid program under the ACA with a special waiver, special permission from the federal government to make changes that are consistent with Republican values. And in fact, the state of Indiana, where Mike Pence was governor, are now vice president, and Seema Vera, who is going to be the new head of the Centers for Medicare and Medicaid Services, she was the author of the law, the Indiana law, that revised their Medicaid program to make it consistent with Republican values. And this isn't my quote, this is her quote. This is what she said when she developed that law. So she's going to be running the Medicare and Medicaid programs at the national level. And it feels to me like there's going to have to be some way of demonstrating to the people who voted Trump into office that the ACA has been significantly changed.
So I'm going to take a question from the audience. Go ahead.
Hi, so thank you. My question is, with the block grants and the repeal of the Medicaid expansions, it seems like the federal government is giving more authority in governance and financing to states. So what do you think are some of the broader social consequences to health inequality between geographic regions and states in the United States?
So I can try to start to answer that. So I think that everything you said is accurate except the financial piece, right? So 63% of the Medicaid program in California is funded by the federal government. So that will start to eat away. And so I think that you're right, there's going to be a lot more discretion at the state level. Much of how states are going to vary, I would expect, is going to be a function of their governance, right? So we talk about what our values are here in California. There's some sense of what that is. I was in Massachusetts before I was here in California. We did our own version of health reform that I think articulated a set of values as well. You can look at what has happened in Indiana. In some ways, the waiver process is a precursor to what we're talking about, right? So states have had some discretion and they've just had to get approval from CMS. I think the nature, in the block grant scenario, that kind of requirement to get permission goes away. And so you'll start to see geographic variation that is reflective of the governance that exists in those states. That's kind of how I would predict you would see that play out. You know, the one thing I would say about block grants, well, I would say a lot of things about block grants, but one point that I would make, and I think we've seen this in some examples of things that have made moves that are similar, is that especially for a state like California where there is tremendous need, if the state is given a bolus of dollars, right, and said, here are your Medicaid dollars, I would suspect that the emphasis would become less on healthcare than it has been. Some would argue that's a good thing. Some would argue that that's a trade-off, and whether that trade-off should be made is a conversation for us to have at the state. But I do think that you start to see some risk with respect to healthcare and healthcare access as those block grants start to give the states more discretion, because I mean, here in California, we've got plenty of things we could spend that money on, all of them laudable things. So those would be some of my thoughts.
So I've got plenty of questions from online. I'm going to keep going back and forth, but if you have a question, you're here in the room, just please hold your hand up so Eric can see you and get to you. And there's also one right here in front. Okay. Is there any hope of preserving any of the delivery system reforms funded by the ACA if the funding for the ACA goes away?
Okay. In theory, yes. And then we get to both the politics and the actors. So the newly installed Secretary of Health and Human Services, Dr. Price, who's a physician, has been on record as being skeptical of the role of the government in trying to impose changes in payment to influence the behavior of physicians or hospitals, but physicians in particular. So sometimes you see a quote that speaks positively from him about the engagement in thinking about value-based payment. In other cases, you basically see statements which say the market should be doing this and physicians should have maximum discretion in behavior. So in theory, you could keep, since Medicare is going to continue to be there and the bulk of the payment reforms are in the Medicare program, not Medicaid, although there are some, or the private sector. You could, in theory, keep the continued focus of the payment reform activities and the quality improvement activities through Medicare in the current legislation. I think those are also likely to come under pressure, either in regulation or in legislation, consistent with the values and beliefs of the new HHS secretary.
Thank you. We had a question in the back.
I have a question for Laura. So I'm interested in the finances for CHLA and the impact that the ACA has had on it. Are you able to track whether or not there's actually been patients who have gotten Medi-Cal or Medicaid through the ACA that you simply would not have seen before, or has it been more of just a shift in payer mix? And what's the impact regardless?
So everybody hates it when I say this, but the ACA has not had a huge effect on us because we had so much coverage for kids. And that's from kind of a direct perspective. So there's a small number of kids who are on the exchange, and Medicaid expansion had kind of already happened for kids before the ACA happened. The one thing I will say is I think that people consume healthcare differently when everybody in the family is insured, right? So the coverage that we've provided that kids have had has been on an independent level, so they're not as dependents of their parents or caregivers. When parents get health insurance, they start to use health insurance differently, and so their kids start to use health insurance differently. And so, use of preventive services and that type of thing tend to be enhanced when folks have access to health care. So I would suspect that that's probably the most kind of relevant effect that we've seen. I think the bigger risk for us is that now that there's this expanded population, and there's likely an interest in keeping that expanded population covered, we're going to start to feel more pressure because kids are going to be in the mix of that, and our concern is making sure that kids don't get forgotten or unattended to.
So before we go to one more in the audience, I want to take one more from online, and this really goes to how do we communicate these very complicated issues. So the particular example that this online person asked about was the axing of the insurance company risk pool payments. How can this be made more clear and visible to the public? But while you answer that question, which actually has profound implications for who's covered, maybe you can also take on that broader question of there are a lot of complicated concepts in this bill. Why, from why it falls apart without an individual mandate, to why the general public should care about block grants to others. So what is the strategy for what really takes everybody's input, getting collective understanding of the changes beyond I have or don't have insurance now, and this is what I pay now?
I'll leave the risk pools to the PhDs, but I will say this. Badger Care is Medicaid. Husky is Healthy Families. All Medicaid and S-CHIP programs have different names in different states. People don't know they're on Medicaid. People don't know they're on the ACA, right? So I even getting to that basic level of communication of what the benefit has been is a place to start. I'll leave it to the others on the more complex.
Well, look, I mean, Louise is absolutely right. How can you possibly talk about risk pools, which is a third level sort of, policy wonk issue, when there are about a third of the population doesn't understand that Obamacare is the same as the ACA. And there are literally Americans who believe that they voted against Obamacare because they hate Obamacare, maybe Obama as well. But they like the ACA, and they didn't realize that they're on the ACA, and they're going to lose their health insurance benefits. So, I mean, we can communicate about risk, but we need to start at a much higher level.
Yeah, I think there are two issues in this question, neither of which I have a full answer for. But we need to look at how we tell the stories about what's going on in the insurance market in a way that is clear and understandable. I think that's talking about the behavior, the insurance company's behavior of patients. So we need to tell stories. And the second thing is we need to find forums, because this is not a question that can be answered in 10 or 20 seconds easily. So we need to find forums for the discussion about the future here that have more extended time periods that allow people to get some of the nuances out, even as they're told in ways that are clear and direct.
I learned much about how we get funding for healthcare for those that can't afford it. But how does the ACA address reducing healthcare costs specifically? And if it doesn't do that, how can we do that to reduce the costs? Because it seems like most of the argument from the other side is affordable healthcare costs are so high. So why are you going to throw more money at a sinking ship rather than fixing it?
So I think shifting the funding from like the disproportionate share hospitals, as was described, and putting money into primary care was one of the ways. And we have the challenge of we put the long and longitudinal on when we're in the primary care. Our impact is felt, much further out. But the delivery systems reforms that were talked about, the waiver programs, payment reform, there's a number of things happening relative to delivery systems and incentivizing outcomes instead of volume. And those need to be maintained, because whatever the cost or whatever the case, we do know that we are going to be needing to do more with less and bending that cost curve.
So, can I just add one thing? So I think that I agree with everything Louise said, and I don't think that was the overwhelming point of the ACA. So, when we did this in Massachusetts, we got everybody covered, it got really expensive, and then we said, okay, we're going to start to focus on cost. And I think there was some stuff contemplated in this space, and the CMMI program and all of that were kind of meant to be an investment in it. I don't think that the ACA contemplated transformative notions about delivery that are going to fundamentally change the cost structures of what we do. So as we look forward, I would argue that that's an opportunity that we have for reform. Some of that looks really ugly, like price regulation and things that none of us want to have happen. But I do think that that's a big opportunity as we move forward from a longevity perspective.
So I'm aware of the time and people having class, including people needing to come into this. On the cost note, I want to ask Jerry if he'll co-host a panel that's focused on cost, because I do think it's a central issue, how we get this under control. We pay twice as much in the United States and get much less benefit, and that does affect many of the other issues that were raised on the panel. Can we address housing, education, income? So I hope we can do a future panel on that. Before you join me in thanking this panel, I want to, in the notion that this is really about all of us changing it, I want to give the last word to the audience, which some of the questions you hear, the rest of what's on people's minds, even though we didn't have a time to finish addressing them, they include if the minimum benefits are eliminated and state regulations undone by portable plans, what are we going to do to protect Californians? What's going to be the impact on families with special needs children? How can counties across California address cascading disinvestments, both at the federal and state levels? Those are just a few of the concerns, so there's much more to address in our future sessions together, but please join me for thanking this extraordinary panel and getting us started.
When did you come from